Thank you so much for a very kind introduction. So, hello everyone. Today we'll be discussing about the GI symptoms. That is part one, and tomorrow I think is the part two. Shri, can you please share the slides as well? I forwarded it on the tips echo wala
Just
email.
one moment.
Yeah. So just to start off, can anyone, so today basically we'll be focusing on nausea, vomiting and hiccups, because I thought that was an important, yes, Dr. Savita, you had something to say? Or is it just hi? All right. Okay, so can anyone just unmute and just define what is nausea and what is vomiting? Anyone? You can type in the chat as well. But just a brief, what is your idea? You don't have to define it word to word as that in our
Yes,
books.
nausea, we can say nausea is a feeling of maybe I or person is having a vomiting, that maybe because of many senses like olfactory problem, means olfactory senses, or looking at some unwanted untoward incidents, we can get a nausea. And vomiting is forceful expulsion of the GI content ranging from stomach to intestine.
Correct. Very good. Thank you. Can you hear me properly? Otherwise, I'll just change my position. You can hear me, right?
Yes, ma'am, you're perfectly audible.
Okay. All right, cool. Next slide, please. So as I said, we'll discuss mainly about nausea, vomiting, and we'll cover hiccups as well, because that is quite common in, especially in cancer patients. Next slide. So I'm sure everyone has vomited at least once in their lifetime. So how does it feel? How do you feel when you either you're nauseous or you're actually vomiting? How is it, like very pleasant, or do you like dread even the thought of vomiting anytime? Anyone? Unpleasant. Yes, it's very discomforting, isn't it? Yes. Next slide, please. So today what we'll do is we will see how to manage nausea and vomiting. So basically there are two different ways in which we could do separately or mixing it together. So one is to identify why the vomiting is or nausea is occurring, and then treat that underlying cause, like remove the cause. So for example, if it is chemotherapy induced nausea, vomiting, then give medicines to prevent that. So that is taking care of the cause. Or you can identify the pathway and you can block the particular receptors, neurotransmitters in that pathway. So for example, as again with chemotherapy, that it's going to act on the chemo trigger zone, CTZ, right? In the vomiting center and up above that also. So you can just block the pathway right up there itself. Next slide, please. So keep this figure in mind, and then we'll come back to it again. So can anyone just quickly tell me what are the possible causes of nausea, vomiting? Anyone, just quickly. Just unmute and just say one. Each of you can also do that. Drug induced, opioids, okay. Anything else? Okay, medicines. Anything else? Radiation of upper GI, okay. Disease related chemotherapy, and commoner ones, like suppose it's not a cancer patient, what are the commoner ones? Why would you vomit? Migraine, okay. Anything else? Pain, brain mets, cerebral, okay. Gastro, yes, gastroenteritis, allergies, vertigo, right? Anything else? Gastritis, yes. Okay. Intestinal obstruction, right? Esophageal, yes. Carcinoma. Motion sickness, yes. Very good. Okay, next slide, please. We'll just quickly go through the. So these are all the M's of MSS, as they call it. This was given to us by one of a very nice faculty who had come from Texas in the US, who taught us nausea vomiting. So I took it from him. This is a very comprehensive potential differentials for vomiting, nausea and vomiting. So above the neck, below neck, and systemic. So that's how they've that's how he divided it. So it was any mass, as you rightly said, meningeal irritation, migraines and headaches, and movement. Movement will be vestibular, so motion sickness, correct. Then again, below neck also masses and metastasis come in. Then motility of the gut, mucosal irritation, mechanical obstruction, myocardial infarction also causes nausea. Maternity, we forgot that it's very common. Mentation and anxiety, medication, as you rightly said, microbes and metabolic. Next slide, please. So again, mnemonic for vomiting itself. Again, the same things as we previously discussed. Next slide, please. So, next slide. Yeah. So what are the pathways? Can anyone tell me what are the main centers for nausea vomiting? CTZ, correct. And vomiting center, which comes below the CTZ. And yes, correct. This will be included in the CTZ in the vomiting center. So that is how it's divided. Next slide, please. So you have your chemoreceptor trigger zone and your vomiting center. So chemoreceptor trigger zone comes above the blood-brain barrier, and vomiting center is below that. So we need to kind of remember that, so that the medications which act will kind of differ. Next slide, please. So main areas where it acts is your CTZ and vomiting center, then the cortex. Then you have your vestibular pathway as well, and the peripheral, which is mainly the GI tract. Next slide, please. And these are the main neuroreceptors that are involved in the process of nausea and vomiting. So mostly all the drugs will act on these antagonists of these medicines, these receptors. Next slide, please. So this is just to briefly tell you which receptors are present or which neurotransmitters are mostly acting in which zone and which centers. So in the CTZ, it's mostly the dopaminergic and the histaminergic receptors, that neurotransmitters that will act there. In the vomiting center is 5-HT3 and NK. Even dopamine. So actually dopaminergic will act in everywhere, almost every place, which will cover almost all the pathways involved in the pathophysiology. Cortex is GABA, vestibular is acetylcholine and histamine, and 5-HT3 in the GI tract. Next slide, please. So again, so how do you approach the management of nausea vomiting? Next slide, please. So it is, as I said, either identify the cause and remove the cause, which will treat your nausea vomiting, or you identify which pathway it is taking and then you block that pathway so you can continue. Like for example, when you give chemotherapy to any patient, it causes a lot of nausea, vomiting, but you cannot stop giving the chemotherapy to those patients because it's life-saving in them. So you identify what pathway it is and then just block the pathway so you can continue to give them chemotherapy and not have any serious side effects as well. Next slide, please. So basically, you need to make sure that it is round the clock. We'll come to the drugs later, but you know that the medicine is round the clock so that there is no intermittent episodes of vomiting. And we need to titrate the dose according to what is needed for the patient. And again, we need to check for the side effect profiles of antiemetic agents as well. And if it is suppose we choose one antiemetic which is not very effective, then we need to add another one which has a different mechanism of action. We cannot just go from the choose from the same class of drugs. We need to make sure that the mechanism of action of the second drug is different from that of the first one. Next slide, please. So some non-pharmacological measures can be cognitive behavioral therapy, acupuncture, relaxation, hypnosis. These are basically for very important in anticipatory vomiting, usually associated with your chemo and radiation therapy, where just because you know that you're going to receive chemotherapy in a couple of days, you start feeling nauseous right at that thought itself. So these will be very beneficial in those scenarios. The rest of them, like avoiding strong smells, small frequent meals, and ginger supplements or cold food, etc., would kind of help in almost all the nausea and vomiting patients, because these are kind of triggers which would just precipitate your nauseous feeling, or the sense to just vomit out. So you can give any patients, you can give these advices, just try and take kind of plain food. Don't take something very strong smelling, or don't go to the kitchen when they are cooking, because that itself can induce your nausea and vomiting. And have small frequent meals. Don't take a large meal because that will precipitate sensations again. And so usually dry in reducing the nausea, and ginger supplements also, because of the taste and everything, it kind of suppresses the feeling of and vomiting. Next slide, please. Then the medications, as I said, antagonist for dopamine, 5-HT3, NK. Your prokinetics, that is your metoclopramide and domperidone, has anticholinergic, steroids, and benzodiazepines. Next slide, please. So where do all these things act? Now, according to the pathophysiology, you could kind of have an understanding where the receptors are, and then accordingly give the medications. So if it is your suppose, let's say, chemotherapy, nausea, vomiting, it will act both on the vomiting center as well as the CTZ. So the involved receptors would be your dopaminergic, histaminergic, 5-HT3, and NK. So giving medicines which act on these receptors is what is usually the most beneficial. So quickly, can you just give me examples of each class of these drugs? Dopaminergic, which would you give for dopaminergic?
Metoclopramide and domperidone.
Right. H1 antihistaminics.
Promethazine.
Right. 5-HT3.
Ondansetron, granisetron.
Right. NK, aprepitant.
Yeah, hyoscine, and NK is aprepitant.
Yeah, aprepitant. Acetylcholine, anticholinergics for vestibular. What do you give for motion sickness?
Hyoscine.
Yes.
Scopolamine.
Yes. So those cover. So basically, it's very easy to remember once will act where and what you would do. Dopaminergic also will have your haloperidol will also act there. So, olanzapine and haloperidol will cover most of the, especially in chemotherapy-induced nausea vomiting, those are very helpful. And especially when drugs which are highly emetic, usually they are added as a prophylaxis in all the regimes as well. Next slide, please. So let's come down to a case scenario. So there is this 70-year-old female with advanced ovarian cancer. She's having increasing abdominal pain for a couple of weeks now, and recently titration of opioids has been done. And now she has new constant nausea. What is the likely reason for her nausea? There can be multiple also, but what is the most likely cause for her nausea? Opioids and peritoneal disease. Yes, correct. So those are the two main things that just pop in your head, because abdominal pain that she's seeing. So there is a mass, obviously, and opioids which have been recently titrated. So opioids can be one of the reasons. Very good. Next slide. So this is how, so mechanism was stimulation of the chemoreceptor trigger zone. Pathway again same, receptors is your dopaminergic, so haloperidol will be very useful. So that there is a not controversy per se. What usually when they say, so even in my routine practice, I have observed that haloperidol actually works very wonderfully for even chemotherapy induced nausea vomiting and opioid induced nausea vomiting. But equally useful is your plain metoclopramide also. I wouldn't say domperidone. Like domperidone sometimes have worked, but I'm not so sure, because it does not cross the blood-brain barrier and all those things. So metoclopramide is equally equally useful, and usually most of the data is usually from either the US or the UK, and their the amount of opioids that they give is way higher than what we generally give in our routine practice. So for them, giving like 120 milligrams of morphine is normal for them. We reach it to a max and then we'll be like, okay, bahut ho gaya, and we are shifting him to either fentanyl or something else to just kind of reduce the amount of opioids that we're giving it to the patient. So but for them it's like, so kind of and generally what I have noticed is, and within 5 days, 3 or 5 days maybe, the nausea and the vomiting that is induced because of opioids generally weans off. So they don't have to take the antiemetics after, let's say, max to max a week. And if they are continuously vomiting even post that, then there's another reason for the nausea and vomiting. So we need to kind of figure that out as well. Next slide, please. Another case. So this is a 46-year-old female. She's a diabetic and has metastatic colon cancer, which has malignant ascites and liver involvement. She has chronic nausea with intermittent vomiting. There is reflux and bloating as well. And eating makes the symptoms worse. What is the possible reason that she is vomiting? Liver mets, yes. And anything else? The last sentence, like, eating makes it worse. So what is that pointing out to? It can be, yes, autonomic dysfunction. Anything else? Colon cancer, in liver involvement, malignant ascites, gastric ulcers. Okay, one reason. Anything else?
Gastric dumping syndrome, maybe due to diabetes. Decreased motility.
Yes, just basically it will not the whole thing must be just kind of stagnant, because there is ascites and there's a lot of pressure on the gut itself. So it makes the movements very slow and yes, gastric status. Yeah. So next slide, please. So what will be your treatment? Like what will be your drug of choice? Metoclopramide, like, motility, prokinetic, basically, to just see if it is helping with that. And if it is, if you're suspecting an obstruction, then something else. We'll come to that tomorrow. We'll be discussing constipation and bowel obstruction tomorrow. So we'll come to obstruction theories tomorrow. Tapping as well, yes, it will actually help with the nausea and appetite as well, and will help in the prokinesis of the gut. Next slide, please. Yes, we have to see for bowel obstruction. Here there is a 38-year-old male with metastatic melanoma. He has acute onset of vomiting, which is usually worse in the morning. And he also reports of headaches. Yes, possibly meningeal involvement. Yes. Next slide, please. So what is the meningeal irritation? So it's again the cortical involvement that is there. So receptors would generally be your histaminergic 5-HT3 and acetylcholine. So they've written the medicine as a steroid. Can anyone tell me why? What is the reason they've given steroid? What does steroid do? Reduces the edema, yes. And anything else? It has its own anti-emetic properties, though no one is very sure what the pathway exactly is. So it, because if you've noticed, it's usually given with chemotherapy as well. DEXA, it generally helps with the nausea as well. So we can give ondansetron, like 5-HT3 antagonist. Yes, it will reduce the intracranial tension. Yes. But it has its own anti-emetic property as well. So here, because we are suspecting raised ICT, so we are giving it as an anti-edema measure. But if there is no, if there is no brain metastasis and no meningeal irritation as well, it has its own anti-emetic property. That's what I'm trying to tell you. Yeah. Yes. Next slide, please. So we come to hiccups. So generally, what can you define hiccups quickly? Like anything, just what is your general idea about what hiccups are? Doesn't have to be right. It doesn't have to. You can just say what you. Diaphragmatic irritation. Yes. Spasmodic reduction, control, contraction. Yes, correct. So we'll just come to the pathophysiology very quickly. Yes, it can be because of uremia. It can be because of multiple reasons actually. Next slide, please. So basically, it is the hiccup center, as they call it. It's in the C3, C5 region and near the medulla and the respiratory center. Usually, the whole pathway, vagal nerve is the main nerve that will be involved. Can you just go till the end of the slide so we have whole of pathophysiology, so it's easier to explain. Next. Yeah. So that's what happens. So basically, the afferents are your phrenic and the vagus, which is generally due to the diaphragmatic irritation or the thoracic and abdominal viscera irritation. And then it goes up to the hiccup center, as they call it. And the efferents are your phrenic and your intercostal nerves. So, sorry. Basically, there is repetitive contraction of your diaphragm and your respiratory muscles, which causes with the contraction of these muscles and plus the activation of your recurrent laryngeal nerve, your glottis closes forcefully, and that the hic sound that comes in, that is how it's produced. So that's why there's a typical hic sound at the end of the breathing. Next slide, please. So again, it's pretty common, especially when you're giving any gastric irritating medicines. It's pretty common. Like here you'll see like only 55 per 100,000 patients, but you will see them quite often, especially if there are cancers of the GI tract, and sometimes even in central nervous system malignancies. Sometimes they are, that is the first symptom that you have, and that's why you go to a doctor. So that occurs in around 20% patients. 10% is due to the reflux disease that you have in the GI tract, and it is almost 4.8% of the patients with advanced cancer will have hiccups. Next slide, please. So there are three types of hiccups. That is acute, which is just recently started. Then you have your chronic, which is around a month of time. You're continuously having hiccups for a month, and intractable is continuously for a longer period. Next slide. 48. Next slide. And so more than a month is continuously occurring and occurring. Next slide, please. So acute, which is less than 48 hours, would be your drinking a lot of carbonated drinks, alcohol, sometimes because of eating too much and kind of spicy food sometimes. Sometimes might be induced because of stress or emotional response or excitement. Temperature changes also sometimes causes hiccups. Then, as I said, swallowing air while chewing gum or sucking a candy might sometimes lead to hiccups. Next slide, please. But these usually go away within 48 hours, like not even 48 hours. It generally goes away almost immediately. So if it's persistent or intractable, it can be because of nerve damage or nerve irritation. Sometimes like for example, hair touching your eardrum, or because of a tumor, or just goiter, which is a mass, like a mass in the neck region. Then your GERD often causes hiccups, and sometimes just sore throat or laryngitis may as well cause. And this is triggered because of alcoholism, anesthesias, barbiturates, diabetes, any electrolyte imbalance, kidney disease, as you rightly said, uremia, steroids and tranquilizers. Next slide, please. So basically, your central nervous disorders will kind of disrupt the normal functioning of the whole body in general. So the control over the hiccup reflex is also disrupted and hampered with. So usually because either of encephalitis, meningitis, your multiple sclerosis, a stroke near that region, or injury or tumors. Next slide, please. So management, can you think of what can be possibly given because for hiccups? Like, for example, so I'll just give you an example, and then just you fluid, yes, baclofen, yes. I'll just shout out the possible reason for hiccups, and then you just unmute and just say whatever medicine you would want to give, right? Okay, so let's say he's having a severe gastritis and GERD. What will be your first line of management? Like, what will be the first drug that you give him?
Non-pharmacological.
For example,
ice cubes to suck.
It's severe gastritis. Like, you know that he has severe gastritis. Pandy, yes, but like supposing oral is not an option because he's just puking out whatever he's megalred. Anything else? Correct. So basically it is, you know, your PPIs and your antacids if if he or she can tolerate it. Or sometimes they even start off with the infusion of pantoprazole. uh Hold it, like if it's severe they can just give, yes, sucralfate is also a very good option for gastritis induced hiccups. Okay, so let's say now it is your it's still not getting controlled with your antacids and your PPIs. Ondansetron, not so much, no, I don't, not. Fluids, yes, fluids will help. But supposing he's not tolerating oral, what is the next? What is another thing? Prokinetic, someone said. So I agree with you. Prokinetic will help, especially metoclopramide. So you have your prokinetics and you have your PPIs and you have your antacid or sucralfate. Anything else? What? When do you give baclofen? When would you want to give baclofen? Haloperidol.
Spasmodic pain.
Yes. So, you know, just to relax the muscles around the drug of choice. Yes. So that is actually first line. Next slide. So we'll just come to first line, second line management now. Next slide, please. So first line is, as you correctly said, baclofen. You start off with a 5 mg TDS and then increase it up to 20 if necessary. For persisting hiccups, yes. So actually, generally in what I have seen in daily practice is that generally everyone starts off with either a PPI and antacid or in combination with prokinetic. If that is not working, then they'll go on to your haloperidol, and then they'll go on to baclofen. But generally, if all the literature says that if it is a persistent hiccup, you will generally first go for baclofen and plus minus prokinetic. So that generally is how what literature says. So first line, as they've said, is baclofen, gabapentin, and pregabalin. Second line they've mentioned is a prokinetic. Next slide, please. Your third line is chlorpromazine, and others can be your anti-epileptics, just to kind of quieten down the nerves that are getting irritated. So that will help, and your calcium channel blockers as well. I personally prefer to step up rather than give multiple medicines at one time, because you will not exactly know what is working for you and not. So just go step by step. That generally and from what I've noticed, generally, antacid and pantoprazole generally helps. Like if that is not helping maximum, you have to go up to haloperidol or something. And supposing you need baclofen, then that is like a very severe hiccups that you've seen, and they also kind of respond with around 5 mg maybe thrice a day. That is the maximum that I've reached till now. I had not had to give 20 mg of baclofen or thrice or 4 times a day. Next slide, please. These are all the non-pharmacological things that you could do, like your Valsalva management and nasopharyngeal stimulation, or cold compresses and carotid massage, induced frights, as we see mostly in the cartoons usually, but yes, induced fright does help, and inducing vomiting sometimes also will help with managing hiccups. Next slide, please. I think yeah, because as I said, your breathing maneuvers and breath holding while salva, rebreathing might also help. So it might help with, but usually it's just these are better for acute hiccups than your chronic persistent ones, but we can just try them. It kind of helps them with the overall anxiety associated with the hiccup episodes as well. Next slide, please. Again, with the non-pharmacological, you can try acupuncture, hypnosis, nerve blocks, and vagal nerve stimulation if possible, if it's the technique is available in the center. Next slide, please. I think that's it from for me today. Thank you so much. Any questions? You are welcome.
Thank you, Dr. Rutula, for that wonderful presentation. Since we don't have a case scenario today, I think the rest of the time we can utilize for an interactive discussion. So if you are having any queries related to the topic, please do feel free to raise your hands and speak up or put it in the chat box.
So ginger actually has a very soothing effect on the general GI tract, like, because it's usually you'll take it as a warm concoction of ginger and not just eat it. And even like, sometimes even candies kind of help with vomiting. So it's just basically that the taste and the soothing effect that ginger and candies have, that kind of suppresses your nausea, feeling of nausea. How much time do we have to wait till? So it goes hand in hand. If it is a kind of an intractable hiccups, I don't think you would want to give a non-pharmacological at that time, because it's already been a month or more than a month that they are having hiccups. So you will give them simultaneously along with your pharmacological measures. We'll be covering constipation tomorrow, so we'll discuss that then. Have we discussed all the therapeutic point of view, or can we use them for prophylaxis? We can use them for prophylaxis. So do you mean to say the non-pharmacological measures, or how? I did not understand your question. The medicines. So, if you mean in like post chemotherapy patients, then they are given as prophylaxis. Many of the times, especially if you know that the drug is highly emetogenic, then you will give it as a prophylaxis at least for a week or so. So yeah, burnt garlic is traditionally used for bloating and gastritis. May I know how? I am not sure. I'll have to read about it. I'm so sorry. I'll really have to read about it, and I'll get back to you on that one. I'll really get back to you on that one. Anything else? Thank you. Does leg elevation have any role in hiccups? Not that I know of. Has it helped anyone? Have you kind of used it anytime? I have not read about it, nor have I used it or seen anyone do that. Usually I've seen people, doing neck stretching, like they just kind of extend their neck a lot and then kind of swallow either a sip of water or something just to get their vagal nerve stimulated, but I've not seen leg elevation. Yes, ginger does have cardiomyopathy. Less pressure on the diaphragm. I'm not sure, but I'll try and find out if I can read it anywhere. How many days of giving antacids and prokinetic should we switch to back? So it's daily assessment. So supposing the patient, you see the patient today and you're planning to give him antacids, prokinetic, and maybe PPIs as well. So you'll have to assess him tomorrow. If at least the frequency has decreased, then you know that it is working, and maybe wait another 2-3 days to then switch. If it's not helping, then switch on to baclofen. But if the intensity is the same or maybe has increased since starting PPIs and antacids and prokinetic, then you will switch on to baclofen. Sometimes nausea causes more problems than vomiting. Yes, I agree with you. The fear of nausea, fear of vomiting is more distressing than the vomiting itself. So that's when you would, kind of give them the non-pharmacological measures, like, don't go near the kitchen, because the cooking smell is quite strong and we use a lot of spices, so that makes it even more pungent and stronger smell, especially tadka vagare, when you put in garlic and your mustard seeds and everything, it's kind of pungent. So that causes a lot of nausea and vomiting. So you would avoid that and then give them just toast and biscuits and something like that to just kind of suppress their nausea. Hiccups is common, yeah, but it generally kind of goes away on its own. It's because their swallowing reflex and everything is kind of new and they're just getting used to it, and they have a lot of aerophagia as well, which also causes hiccups in babies. So but it generally goes away after positioning and just patting on their back. Medicines that can help patient to reduce nausea apart from dexamethasone. All your antiemetics, usually 5-HT3 helps with the nausea part as well. Then you can give haloperidol also, that because it is an antipsychotic as well, so will help with that. Even olanzapine helps with nausea. Anything else? Use of straw for liquid helped my patient reduce nausea. Yes, yes, and generally you'll give kind of cold food with the straw, so that. I generally start off with haloperidol once a day of around 1 mg per day, and then I escalate it according to his or her response. Anything else? Thank you. I'm glad you found it useful. What is preferred for nausea-induced haloperidol? They say dopaminergic will actually have a better effect than me, but prokinetic, that is your metoclopramide, is equally helpful. Oh, okay. Oh, great. Okay, gingers are 5-HT3 antagonists. Oh, great. Thank you. I did not know that. Thanks. Thank you so much. Thank you. Great. Nice. Thank you. Glad you found it helpful. And tomorrow we'll meet at the same time about constipation, and I think we'll cover intestinal obstruction tomorrow. So those are the two topics for tomorrow.
Any other quick questions, Dr. Rutula? like to take in that, because I also believe that she is having a really tight schedule and relieving her half an hour before the session might be very useful for her. So in case no one else is having any other queries, maybe we can temporarily say data to her and then see her again tomorrow. Any other last questions for her?
Okay.
I guess not. So, believing that there is no more further queries, Dr. Rutula, thank you so much for joining us for yet another wonderful session. And it was indeed our pleasure, and looking forward to many more sessions with you, ma'am. So, with that note, this is Sri Priya,
Definitely.
along with Dr. Rutula, signing off for the day. See you tomorrow again with the second part of
Thank you.
gastrointestinal symptoms. And before signing off, just one request that in case anyone is having any relevant, interesting case scenario to be brought in, please do bring it in so that we can have more discussions.
Thank you.
So,
Thank
thank
you.
you, everyone. Take care. Bye
Thank you.
bye.
Bye. Take care.